Good evening. My name is Marcus White, and I'd like to welcome you all to a webinar that we're giving tonight on atraumatic extraction. I am a practicing periodontist in Cedarhurst, New York. I'd like to begin by thanking our sponsors, Voco, for making this happen to begin with. As I started to say, I am a practicing periodontist. I practice with really wonderful partners, Dr. Barry Behrens, Dr. Dan Gober, Dr. Paul Schneider. Some of the material you'll be seeing tonight is their material, not only mine, and I'm privileged to share it with you. By way of disclosure, I also have an interest in an implant company called Adin Implants. Adin is really a wonderful, wonderful implant. It's a tapered spiral implant that's really priced aggressively with a very, very, very high quality product. And you'll be seeing a lot of Adin stuff today as well. Again, Voco, really wonderful, wonderful people. A shout out to Nicole for making this happen. And wonderful products as well. You'll see some nice Voco cases that we've done. And I hope that you'll try it. It's really wonderful. The implant restoration begins with atraumatic extraction, clinical pearls you can easily and immediately use in your office. And so we are clinicians here in our office, and we do many, many implants. I'm in New York. It's 8:30 at night right now, coming after a long day when we've done many implants today, as we do every single day. And not every, but most implants begin with an extraction. And I hope what you'll see today and learn today is the beginning or the foundation for appropriate implant placement. Our goals for tonight include the concept of what really an extraction is, discussion on socket healing and grafting, extraction techniques, immediate implant placement or restoration, as well as perhaps learning from some of the mistakes that we've made through the years, and we've learned from them so that you could learn from our mistakes and not make the same ones. So let's begin by speaking a little bit about what an extraction is and how an extraction works. So on a simple level, an extraction is obviously removing a tooth. There are three basic ways to remove teeth. One is by wedging, the second is by luxating, and the third is by pulling. A quick review of anatomy is in order, where you have a natural tooth which is held in place and attached to bone with periodontal fibers and periodontal ligament, which actually holds it in place. So when we extract the tooth, we need to sever that connection so that the tooth will simply slide out. Wedging is a concept where we stick something in that's the shape of a wedge, aka an elevator. And as the wedge goes in, we of course know that two items can't occupy the same space. So as the wedge goes in, it pushes the tooth up, but it also puts an inordinate amount of pressure on, and it expands the ridge as it's doing that and deforms the ridge as it's doing that. Luxating is where we grab the tooth with something, with some sort of forceps, and we twist the tooth. We rotate it side to side. And as we rotate it side to side, we're going to sever those fibers, and the tooth will come out. Pulling, as opposed or in deference to luxating, we're not actually rotating, but we're actually going to put forceps on and try to schlep the tooth out or pull the tooth right out. So there are basically different concepts of extraction. We'd like to differentiate into two categories of traumatic and atraumatic, and clearly the focus of our lecture tonight is on atraumatic extraction, meaning that we're going to try to keep the entire bony complex in place and the entire gingival complex in place as well. And that's going to be our basis for a potential healthy aesthetic functional implant restoration. So traumatic, we'll look at some examples of traumatic extraction, and you can see over here where we're flapped and we're missing the entire buccal plate. Or over here, where we're missing the entire buccal plate, the tooth is fractured, and we still have a little piece of tooth here that we still have more room to go. And here, of course, the tooth is extracted, and you can see that it came out with a little piece of tooth. And I think you'll see this this exact tooth a little bit later. I don't know if it's this exact tooth or a different one, but we'll show you how we handle this when we can. Here's an example of an atraumatic extraction where it's very nice, very neat, very clean. It almost looks like that existed before without the tooth there. And so certainly there's some bleeding, and we'll get to bleeding in a moment because bleeding is necessary in order to begin the healing stage. Here's another case of a very nice atraumatic extraction where basically what we have is a hole where the tooth was, but everything else is intact, very nice, very stable, very healthy. And here's a case where we've extracted a third molar, and again, very nice, very healthy. We're going to show you a little bit later in the presentation how we do that. Most times we'll actually go ahead and place an implant immediately right into that space. But the only way to do this with a third molar like this is to cut it into pieces and then take out the pieces where the sum of the pieces equals the whole. Because these are divergent roots, and certainly if one were to go ahead with any of the regular techniques and try to extract it, they would inevitably extract some bone as well, either the buccal plate, the palatal wall, or very usually this big hunk of bone in between. So let's talk a little bit about socket healing and grafting, and we're going to get to really the juice of the presentation once we get by, I guess, the next 5 minutes of this basis or foundation, which is necessary. So when we extract a tooth, what we have is basically a race between the soft tissue and the hard tissue to fill the socket. So over here you can see we've extracted a tooth and there's an empty wall, there's an empty socket. And this illustration, which comes from the Gore-Tex company, comes in over here to show us that the bone is racing up and the gum tissue is racing down. What's very interesting, and we have these slides a little bit later, but if we didn't have this piece of bone over here, we wouldn't be having a race like this. And instead what we would have is the soft tissue would just heal just like that. So right over here in an illustrative way, it's very easy to see how important it is to maintain that little piece of bone over there. It's important for us to understand where our blood supply comes from, because what comes with the blood are the cells that initiate the healing process, which then differentiate into our bone, into our soft tissue, and into the nutrients as well. The blood is bringing the nutrients as well for these things to thrive and to grow and to heal as we understand healing. There are all kinds of grafting materials that we could use. Bioos, demineralized freeze-dried bone allograft, calcium sulfate. There are many others as well. And certainly we can have a little discussion about grafting materials. It's important to be clear that it's the concept behind the materials and not the materials themselves at this point in time, which is important. And so when we think about the previous slides where we had that little piece of bone, those cellular elements are coming from that little piece of bone. And what the grafting material does is it helps preserve the space, it helps a clot stabilize, and so it'll help maintain space and set up an environment for proper healing. But the materials that we're using today don't actually cause bone to grow. They help bone grow, but they don't cause bone to grow. The materials that cause bone to grow already do exist. They exist with growth factors. We're just not using them because they're not commercially viable just yet. So the future may change, but at present, when we talk about grafting materials, the materials that we use, for the most part, are materials that maintain a space. It's important to talk about the different kinds. As we said, there are allografts and xenografts, and really what they do is they form a scaffold for vital bone formation. The goal is that ultimately the graft material is resorbed and replaced with vital bone. Although this isn't always the case, the qualities of the different grafting materials are important in realizing the amount of bone that we have. So being that this lecture is really about implants and setting up a foundation for implants, implants will never integrate into a bone graft material. It's not a living material. Implants need living bone. And so the various materials that we use, which we said act as a scaffold, cause bone to heal and cause the spaces to heal properly. Ultimately, our hope is that they are resorbed. Xenografts take a little bit longer to resorb than allografts, and this may play a role in our choice of material when we're trying to figure out what to graft with. It's important to discuss a little bit about what guided healing is, or guided GBR is guided bone regeneration. We already looked at this slide where there's a little bit of a race, and when we have it like this, what we'll end up is reaching some sort of a compromise where we've lost some bone. This little peak of bone will usually resorb a little bit, and we'll end up with some resorption like that. In his landmark research, Urist in the late 60s came out with the concept of guided bone regeneration, which simply was that if we can put a barrier in place, compartmentalizing the different cellular elements, meaning we can separate the bone and the gum tissue, then this area will heal with bone because the cells that are populating this area are bony cells, as opposed to this situation where we're not placing a membrane. The soft tissue will invaginate in as the bone invaginates up, and this situation will heal very much like this. In these illustrations, you can see that a bone graft has been placed, and the bone graft, as we discussed, fills the area and keeps the space, but it doesn't cause healthy bone to grow or not grow. The same is true if we use a membrane without bone, because if we use an implant without bone, if the implant supports some sort of a barrier and we're able to create a space, as illustrated right over here, this area will heal with bone. However, if we don't have the barrier here and we simply leave this implant as the diagram shows and suture closed, we'll end up with soft tissue in apposition to the implant all along this area. It's also important to mention that more and more commonly we place implants directly into extraction sockets. And as we go through the clinical portion of this presentation, which is about to begin, you'll see that resonating over and over and over again. And so it makes it even that much more important extracting teeth atraumatically, because in actuality what we're doing is setting ourselves up for implant placement immediately right into those sockets. So let's take a look at what that looks like. And we can see over here just photos of implants placed into sockets. Sometimes there's a big void in between the implant and the bony wall, but I assure you that there is a bony wall over here. You can see that we've used different kinds of implants. And over here you can see that exact case that we spoke about before, illustrated with an implant placed into the interradicular bony septum. What's very interesting and very nice for our patients in our practice is that this is all done without cutting our patients. So no flaps have been raised, which means that minimal trauma has been caused, and most of the patients heal very nicely. Which brings us to the meat of our presentation. There are various extraction techniques that we can employ. And so we've just listed some of the extraction techniques that we employ in our office, using some of the older technologies and some of the newer technologies. And there is no one right technique or one right way to take out a tooth. Whatever way works for you and for the exact situation is the right way to go. It's important that you have available all of these different techniques in your armamentarium, and that you can use the best technique possible. Just this week, 3 days ago, I ended up using a piezoatome 3 times in one day for extracting root tips. We do use it, and I think a shout out to the Duell company, which is the piezoatome that we have in our office, is really mandated. Duell has done a great job in bringing a piezoatome to market, which again is very fairly priced. Of course, the gold standard is the Metron machine, and it's also a wonderful, excellent machine. So let's begin by luxation and see what that's about. If we just go ahead to pull this tooth out, then in all likelihood what we're going to end up with is pulling some bone out as well as the tooth, because the periodontal fibers and the periodontal ligament are connected to it. We may rip some of the soft tissue. So instead of that, we can rotate the tooth from side to side and side to side separating those fibers in that periodontal ligament, and that way we can end up in a clean end result with a socket that looks like that, all ready for implant placement. And here you can see the tooth has been extracted and an implant has been placed. This is a case, I believe, that was done by my partner, Dan Gober. And it was loaded immediately. You can see with this little screw that an immediate temporary was placed, so the patient was able to leave with a tooth right away. Let's have a look at that and see how that worked out. And so over here, what we're going to do is we're going to begin by using an elevator to separate the fibers of the soft tissue so that we don't tear any soft tissue as we go through the process. We're going to very, very carefully use extraction forceps. We're using forceps here that were made by Titan, a very, very nice modification to the 150s, which have little elevator beaks at the end, which actually slide underneath the gingiva, so you can actually elevate. And you can see by rotating and very carefully extracting, we're able to luxate the tooth out very carefully and keep everything intact. Of course, there are many, many different kinds of elevators that we can use, and very often we'll use an elevator in its entirety to extract the tooth. And the elevator uses the wedging technique to go in between to actually push the tooth out by pushing the elevator in. So let's have a look and see what that looks like. Over here you can see we're very, very carefully, we have a broken root tip, and as we push our elevator in, you can see how very, very slowly the tooth begins to move. This is a periotome which we're using, which is, I guess, a modification. We'll get to periotome in a little bit. And the periotome is just much, much skinnier, and we can actually slide it down and below and loosen our tooth to make it very, very nice to extract. And in this particular case, you can see we're going to remove it with college pliers because we were able to loosen everything by using an elevator to create the space and loosen it a little bit, and using the periotome after to go ahead and sever all the fibers. What that does is it helps us keep all of the bone intact right over here, again, setting us up for immediate implant placement. And you can see we went ahead over here in this case and we placed our implant right into the socket because we were able to maintain all of that bone. Here too, that implant was immediately loaded. Have fun getting this tooth out. So over here we have a tooth which is obviously very decayed and all broken down to the level of the bone. You can see what that looks like clinically. And so how are we going to go about this? How are we going to go about taking this tooth out yet preserving all our bone? So certainly an easy way is to flap it, use a high-speed handpiece. In the olden days in the oral surgery clinic, we were taught to use a Hall drill, and go ahead and remove some bone and then really destroy the entire bony complex. But instead, we're going to think a little bit out of the box. And what we can do is we can ditch it. So you can see what the tooth looks like over here. We can use a high-speed handpiece to create a little moat or a little ditch all around over here, giving us some space to go ahead and extract the tooth. And because we did that, we're able to extract that tooth atraumatically. And over here you can see we've placed a very, very nice, stable Adin implant at very, very high torque. I usually place these implants at between 70 and 90 newtons of torque. It looks like we placed a 5mm implant over here. And you can see that what we were able to accomplish is extract the tooth, place the implant in one shot, and in most cases we're able to provisionalize this as well. A word on the implant. The implant is a tapered spiral, and this is an excellent X-ray to demonstrate that. So if we look at these walls, they're almost parallel going from side to side, but there's a tapered core on the inside. And what that does is it dramatically increases the torque as you're placing the implant based on how you instrument to place the implant. So there are little micro threads on top which you don't see, but what's key is that the implant goes in very, very stable at very, very high torque, which lends itself to immediate placement and immediate loading, as well as obviously long-term success, the same as all other implants. So let's look at a periotome and how we could use that. And we showed you one case where we used a periotome. Over here is another case. I'm sorry that my light is in the way of the video, but using a periotome takes patience, lots and lots and lots of patience. You need to go very, very slowly as you tease this very, very fine instrument into the space where the periodontal ligament is. And basically what you're doing is you're very, very carefully severing it, separating it. You can see that the instrument, we're holding it like a pen. It's not really like an elevator where we can put force on it and torque the tooth out. But if we're patient enough and we take enough time, then of course, as you saw, that root will come out. We'll be victorious in maintaining the buccal plate. What about a case like this? Ouch. How are we going to get this tooth out? We know that when we go ahead to remove this, what we're going to be left with is something that's subcrestal. So how are we going to get that tooth out? So I'm going to show you a few techniques in the next few minutes, potentially, that we could use to get that tooth out. But right now, what I'm going to show you is one technique that was employed already using the facilities that I've showed you, meaning using a periotome to get that tooth out. But how are we going to tease a periotome into that space? And so this is what it looks like. Clearly, we have an occlusal problem as well, and you can see we have substantial wear. Over here, the tooth, we pulled the portion of the tooth out, and you can see, just as we predicted, it's broken subcrestally below the gingiva and below the gum. I thank Dr. Gober for taking these videos, and this is a case that my partner, Dr. Behrens, did. Really an amazing feat, extracting that tooth atraumatically. And so, using the concept of a periotome, you can see what he's doing is he's using a scalpel. It looks like a 15 blade on that, which is ultra thin, and he's actually cutting the bone and cutting the periodontal ligament as he places that in. But because the root was so subcrestal and there was so minimal space left between where the tooth root was, and where the surrounding bone was, he's using a mallet and very, very gently tapping this in. I absolutely do not advise someone without really a tremendous amount of experience trying to do this with a 15 blade. You're liable to cut up the whole lip. You're liable to slip and cut up all the gingiva. This is really something that only a seasoned veteran like Dr. Behrens should ever try. But you can see how skillful he is over here as he takes the periotome or the scalpel, very carefully taps it in, pulls it out, goes side to side, side to side. And over here again, he's using a root teaser, very much like a periotome. And what he's going to do is remove that tiny little piece of root. And you can see over here how cleanly he did. The root is totally removed in its entirety, and the socket remains intact over here with bony plate to support the future restoration. You can see how it falls in a little bit because there was a little bit of bone missing already, and that's because it was broken subcrestally over here, and this bone didn't exist. And so this is a little bit of an issue that we would perhaps want to question on how to deal with. Over here we have the socket, and what we're going to do is we're going to go ahead and place an immediate implant right into that socket. And again, it's an Adin implant, a tapered spiral going in at very, very high torque. You can see how we're really not worried over here that the implant is not occupying the entire space. And you can see the space right over here. We are going to graft that space with the grafting material. We want to support the tissue. We want to maintain the bone in its entirety along the outside. The graft material is going to help do that while it supports a clot and helps create a space for bone to heal as the bony cells populate and it's resorbed. What about a provisional? So in this particular case, we're going to use components that Shetel sells. Shetel distributes that did in the U.S. Called a Tic Tac kit. It's a temporary implant kit, temporary implant components. In this particular case, we're going to use these temporary implant components. It's a really very lovely kit that comes packaged with 3 pieces. A temporary abutment, a relining sleeve, which is made of PMMA, polymethyl methacrylate, which relines very easily to jet acrylic or any other kind of acrylic. It also relines to materials like Voco Structure when you prime it with a material called UFI gel. And we'll show you that in a little bit as well. Very nice because it comes packaged with an analog, and we'll show you in a minute how you could use that analog to go ahead and make a temporary. So over here we've placed this component in, and this component can get placed with two instruments. There is a standard hex instrument which goes around the outside, or there's an 050 hex, which is the regular screwdriver that you are accustomed to using for ADIN implants, MIS implants, BioHorizons, Zimmer implants, Straumann implants, all use the standard 050 hex. So I'm sure that you have that already. You have all the armamentarium necessary in your office should you want to pick up this kit. And we're going to place that implant in place. We're going to place the abutment onto the implant in place, just like that. In this particular case, we're going to do something novel, which is we're going to use the crown that we salvaged when we removed it, and we're going to hollow it out. We're going to etch the crown with Voco universal bonding agent, and then we're going to reline it and pick up that little piece, that little plastic PMMA sleeve, and then we're going to take it out of the mouth, put it back onto the analog, and outside of the mouth we can go ahead and create this beautiful temporary with magnificent contours to fit our implant. Again, all of this is done without flapping, and then we can simply take this and reseat it. And what's another thing that's very nice about the analog is that it could be used in the cementation process so that we don't have excess cement. You see there's no excess cement down here and down here. These pictures always look a little bit funny because there's a phantom space. The acrylic that was used to reline it, and you can see it right over here, it's all full of acrylic, is radiolucent. It doesn't show up on X-ray. So it looks like the crown itself is just hanging in air. But what's really beautiful about this is we've taken our own tooth and put it right back in, and this person couldn't be happier because our patient is going home with the same tooth that they originally had, only now it's secured by an implant. It's rock solid. The implant had gone in at over 70 or 80 newtons of torque. Nonetheless, we'd like this to heal in a minimal loading environment, so our advice to the patient is to try to stay off it during the healing period. And of course, we need to adjust the occlusion the same way. And this is what it looks like when the patient comes back and the crown is finally restored. And you can see how beautiful a restoration it is. We've maintained our mucogingival complex. We've maintained our gingiva in the right place. The ADIN implant has innate platform switching that you can see right over here. So we're hopeful that our bony peaks are going to stay intact, and hence we've maintained our papilla, and we're hopeful that our papilla will remain intact. What an amazing service to our patient to fracture an anterior central and literally 2 hours later leave with the same tooth there and be set up for a magnificent restoration to follow, maintaining the entire gingival complex, mucogingival complex, as it originally was. What an amazing, amazing service. What an amazing concept that literally 10 years ago we couldn't even think about. Today, this is routine. In our office, we do this once a day, every day. And I know that sounds like an exaggeration, but it's really not. That's what we do. That's what we've become known to do. And people somehow find us. People send them here. They find us. They know that they're going to leave with teeth. No one leaves without teeth. And while we still utilize flippers in our practice, really less and less and less, I'm going to say most of our patients do leave with some sort of a fixed, either cemented or screw-retained restoration. Here's a different kind of a tic-tac kit, and this is also a kit that's sold by ADIN in America, by Shuttle Industries. This comes packaged with several pieces, and so it comes with a prefabricated abutment, a similar analog to the one I was describing, waxing sleeves, both indexed and non-indexed, so it can be rotating or non-rotating, a comfort cap that snaps over here so that you can maintain the space, and this acts like a healing abutment, and this little plastic jig is an impression component so that once you put this abutment on, this is calibrated to slip right over that, and it's very easy to take an impression. What about temporary? So let's talk a little bit about Voco structure. It's really a wonderful material that's very, very easy to use. It comes packaged in a gun material, so it goes into a gun, you squeeze it out, it sets very quickly, it comes in multiple shades, it's very easy to polish and to shape, and let's see how that works. So over here we have a case where this tooth needs to be removed, and the patient doesn't want to leave without a tooth. This is what it looks like going all across, and you can see it's totally decayed out over here. There is some sort of a temporary material over here. We have a very, very hard occlusion. How are we going to do this? Well, we're going to follow some of the principles that we just talked about. We're going to be very, very careful to atraumatically extract this tooth, and you can see we've maintained all the different pieces of it. And we're going to place our implant right in. In this particular case, we're going to go into the palatal socket. We're going to cheat a little bit going towards the mesial, so we're not straight in the palatal socket, but we're going to try to exit slightly palatal over here because that's going to make life much easier. We do want to maintain this buccal wall over here, which means it necessitates us grafting this socket so that we'll form a clot, will support our thin bony wall, and will heal, hopefully, with our full bony complex. In this particular case, we're going to use a plastic component as well that Adin sells, and we're going to mark it up. We're going to roughen it up and sandblast it. This kit comes packaged with several screws, so we're going to use a long screw over here that goes right onto the implant, and you can see that this is going to stick out. We're going to take a prefabricated ion crown and cut a hole in it so that this ion crown can simply slip on right over here. Excuse me. Of course, this all begins with the atraumatic extraction and the site preservation. It also commences with appropriate implant placement. You can see how nicely the implant is going to exit, almost dead center, slightly cheating to the palate, so that we're going to be able to do this very, very nicely as a screw-retained restoration. This is really a wonderful product from Voco. It's a primer for PMMA, and what it does is it basically prepares the PMMA so that it could bond with acrylic, and it can also bond with structure. It could bond with various materials. So we're going to paint the UFI gel on. Over here, we're going to apply the structure. As I said, it comes in a gun cartridge. We're going to squeeze it out very easily. We're going to place some on the plastic abutment that we put in place. Let's go back over here. So this is what the plastic abutment, the PMMA abutment, looks like. And you can see how it's screwed in place over here with a long screw which is coming out through the center. Once it's primed, we're going to squirt a little bit on. Instead of freehand carving it, which we can, I don't remember if we show that to you in this lecture or not. If not, certainly we showed it to you in the previous lecture we did on Viva Learning. And I guess it's relevant as well to give a shout out to Trung from Viva Learning for facilitating this. Not only facilitating it, but really making it easy and a pleasure to work with. So thank you, Trung. And so right over here, we're going to squirt out some of the structure material. This is structure 3. This is the cartridge that it comes in, and you can see it's A2. It comes in various materials. We're going to retrofill the ion crown with some structure and simply place it on. We've already tried it in, so we know that the access is dead on in the center, and it's going to come through the hole we've created. And very quickly, this thing sets very, very quickly. Inside of a few minutes, it's going to set. We're going to begin trimming it. We're going to take the screw out and totally out of the mouth over here. We're going to put it on an analog, trim it up right over here. Here's an analog again. We're going to take it out of the mouth, put it on an analog, trim it up to get very nice, smooth contours. Over here, we're using a trimming burr by the Comet company. A very, very nice little system with 3 burrs made for trimming acrylic and polishing them. And you can see what we've done is we've created a very beautiful contour. We've maintained our height of contour where it needs to be so that in the mouth it's going to look very aesthetic. You can see our angulation. We're going to exit dead center through the top of the crown. And really inside of a few minutes, 15, 20 minutes using this structure material, we're able to go from here where we've placed our implant. You could see how we've grafted the socket as we've discussed before. We're maintaining our entire complex over here. We're going to screw this temporary that we made outside of the mouth. We did the pickup in the mouth, but we basically created it, fabricated, and you can even see occlusally with a nice high shine polish. We've pumiceed it so that it's really polished nicely. We're going to adjust it so that it's It's just slightly in occlusion, which is the very, very small point contact, no lateral excursions for immediately loading these implants. We're going to fill it with some Teflon tape and seal it. Teflon tape is another product that Adin sells, a very, very nice little pearl for you, where you could seal the inside of the chamber for screw-retained implant restorations with Teflon prior to sealing the top. We're accustomed to using cotton, and those of us who do it on a frequent basis know what that cotton looks like when we go to take it out afterwards if we ever need to retrieve it. There's never enough cotton. Sometimes there's too much cotton. It's hard to get out. It frays. The Teflon is very nice. It packs right in. You can actually compress it. At the end, when you need to retrieve it, you can drill right into it, and it's not a problem. It gives you a positive stop when you do. And usually with one hook of an Explorer, the entire Teflon pulls out and just unwinds. Very, very nice little trick. It's important for us to talk about some of the other materials we use and how else we can do this. When we're not using structure, we're using very often flowable materials like Grantech and Grandioso. Grantech is a wonderful material that Voco makes, and basically it's a fiber, a composite impregnated fiber. So it comes with this fiber right over here, and it's impregnated with composite. So you simply open it, cut it to size, place it, cure it with a light, and it acts as a terrific scaffold for making temporaries and for holding all kinds of things together. Grandioso is a wonderful composite that they use, very easy to use. It comes in a heavy flow, and it's just got the right amount of body so that it goes where you want it, but doesn't mush around too terribly. Very easy to polish, and just really comes in many shades. Nice to use, easy to handle. Let's look at a case and see how we can do that. So here, again, we have a tooth that's slated for an extraction. We would like to replace it with a temporary, but in this particular case, once we extracted the tooth, the socket void was too big. There was a big infection. We degranulated it in total so that we're going to get good healing. Again, very careful atraumatic extraction. You can see very little damage to the surrounding soft tissue, no flapping, no removal of bone. In fact, the opposite, maintenance of all remaining bone if we can, maintenance of all of the contour. We're going to graft it. It merits a shout out to Geizlich and the Biowas company. We do use a lot of Biowas. It just, it handles well. It's probably the most studied grafting material out there. It heals very nicely. While we'd like to believe that it totally resorbs, the reality is that it doesn't totally resorb. Some of it does resorb, but it provides a very, very nice scaffold. And in many, many histological studies, which there are many, the bone-to-implant contact is really fantastic with the Biowas, so that we can place our implants immediately. We can place our implants in a delayed fashion, and ultimately we'll end up with bone where we need it, as we need it. In this particular case, we need a provisional, and we can't go ahead excuse me, and do an immediate load because we didn't place the implant. And so you can see we had a composite restoration over here that needed to be replaced anyway. So what we're going to do is we're going to dimple it a little bit to give us a little bit of a positive seat. We're going to go ahead and trim our Grantech, and this is exactly what the Grantech looks like. You just cut it to trim it. We place it in here. We hit it with a light, and boom, it's in. It's bonded right over here. We did etch and bond over here, even though it is a porcelain restoration. We primed it, and this will stay, hopefully, during the course of the healing period. The really nice thing about the Voco material, the etch, the universal bond, and the material, it creates a very strong bond over here by creating this little dimple and using the scaffold. Even if we didn't have this, I'm confident that this is going to stay in place. And so let's see what that looks like. We're going to use another little trick by a company called Uveneer, an Australian company, and we're going to use the Uveneer to help us create a very nice temporary very quickly out of composite. You can see Uveneer is a clear shell. We're going to fill the Uveneer, place it, cure it. It's made out of clear acrylic so that once we've filled it, we can cure right through it. Very, very quickly, this is what it looks like. And you can see very quickly, very nicely, we've created a very nice, highly polished composite restoration. We've kept our occlusion light on purpose so that we don't displace it. You can see we've created a very, very nice broad contact over here. Just beautiful, nice material, very easy to use, maintaining our soft tissue, our underlying hard tissue, so that ultimately we can go back and place a very nice restoration. So what's new? We've showed you a lot of things, given you a lot of information. One of the things that's new is a new kind of a periatome. I picked this up from Duell. We spoke about Duell just a little while ago, and what's really neat about this is it's a bendable periatome. And you can see how nice that is, because as you slip it in between the tooth and the bone where the periodontal ligament is, when you apply a little bit more pressure, it basically bends to get out of the way and conform to the shape of the socket, making it not only easier and more effective, but actually putting a positive pressure on the tooth for the tooth to come out as well, because it has some spring on it. So let's see what that looks like right over here, and you can see how we can bend it, and it just will bend right on when you apply pressure. In this particular case, we're not going to do that. We showed you this socket earlier on. How did we get this out so cleanly? We're going to use an instrument and a system that's sold by the Titan company called Easy Extract. And Easy Extract is really a wonderful, wonderful modality. It's a little bit on the expensive side and on the time side using it. So you need to have some patience. But the reality of it is it saves time because you don't struggle removing teeth, you don't struggle removing broken roots, and ultimately when they come out, you're left with a beautiful, perfect socket as you are over here. So let's see how that works. Over here we have a tooth. We want to go ahead and extract it. How are we going to do that? Well, the way that the Easy Extract works is when we take this crown off, we're going to be left with just this broken stub of a tooth. You can see what the tooth looks like over here. We're going to use their instrumentation to create a special post-prep, and we're going to use this little device, which is a long pin that screws into the tooth, giving us something to grab onto so that we can remove the tooth easily. And what it allows us to do is remove the tooth, place the implant immediately because we can maintain the socket, and here you go. We can end up with a complex that looks like this, totally maintained, and we can provisionalize it immediately, and our patient can leave with a tooth. In this particular case, we're going to use a standard abutment. We're going to trim it, and you can see how we've trimmed it a little bit. Our angulation is for an incisal access for a cementable case. So you can see we're accessing right over here. We've trimmed back just a little bit. We're going to use a shell that we created out of Coltaflex before we extracted that tooth. We've hollowed it out. We've placed it, and we've trimmed it as we've showed you before. And here you go. And that's what it looks like. This is what the original crown looked like. This is what it looks like right now. Again, using this matrix to help us create a temporary by retrofilling it with temporary material, taking it out of the mouth onto the analog. In this case, we're going to use the actual abutment and take it out, and it helps us polish this to this very, very beautiful, nice contour. If we can draw an imaginary line right over here, you can see how nice that looks, and exiting in the mouth, it's going to look very nice, very natural, really almost even better than the adjacent tooth. And the reason that this is possible, this is all made possible because we began with the Easy Extract system that Titan gave us to extract this tooth atraumatically, maintaining all of our bone. And that's what the patient went home looking like. Really a very, very happy, ecstatic patient. Let's look at what that looks like. SIPI stands for South Island Periodontics and Implantology in Cedarhurst. And over here is another case where we're going to go ahead and use the Easy Extract, and you can see right over here, we're going over here, we've removed it, we're creating our access, we're using their pin and using a ratchet that they've provided to secure it in place. We're using an impression tray with bite registration material provided to us by Voco, which sets very, very quickly. Over here, I'm sorry, the bite material was provided to us by Kettenbach, and it says very, very quickly. Kettenbach makes really great material. I'd encourage you to look at that too. And you can see a very nice, very quickly, by using this device, which is that pulley system that we just had, what we're able to do is, I can't go back easily, so I'm not going to. We can go ahead and extract that tooth. And you can see how the tooth comes out with the pin in place, and we're all done. And again, I do want to thank my partners for teaching me how to do all these things and helping facilitate both the implementation and the video of it. And so here we are reviewing. You can see exactly what it looks like, broken tooth. The traumatic way might be to go ahead and flap it in order to extract it. And of course, that's what it's going to look like, and we're going to have slow healing. We're going to disturb our mucogingival junction. We are, of course, able, even with that way, to place the implant immediately and hope for a good result. But today, we really have a tremendous armamentarium, and we have tremendous possibilities to do that without having to do that. And so one of the last pieces of instrumentation that I'd like to introduce is a piezoatome, which is a machine that vibrates ultrasonically. And what's very nice about it is that the vibration is set to a frequency where it cuts bone, but really not much else. And so by doing that, we don't have danger of vital structures. We're not going to cut any soft tissue that we hit. But what we are going to do is create, very much like with a periotome, using the right tips, a nice situation where we can go ahead and remove a tooth that we would otherwise not be able to remove easily. And here's what that looks like. Here's, again, a broken tooth. As the top portion, the crown comes out, this is what we're left with. You can see the mush. I don't know what this dentist was thinking. As we begin to clean it out, you can see the whole top section of tooth is decayed. And what we're left with is really just this little tiny root back here without removing a lot of bone. How are we going to go ahead and remove that? So let me show you how. We're going to use the piezo, which we need to use copious amounts of water because it does generate heat, and we don't want to burn any bone because that's going to impede healing. Very, very gently, using a waving motion, a back and forth motion. We're going to create a little trough, a little space, excuse me for that, between the root and the surrounding socket. I need to thank Becky Fatir, my assistant, who's really first class, and you can see, you almost don't see the water over here because she's doing such a great job suctioning for us. But if you look carefully, you'll see that there are really copious amounts of water, and we're going to create a little trough. And that's exactly what it looks like, and you can see how beautiful that is, because this tooth really, by going around the way we did, is really only marginally connected to the bony complex right now. Very easy for us to go ahead now and pluck this out with college pliers the way we showed you before, or by sticking a periotome and basically flicking it out, especially with the newer bendable periotome by Duell. You can see the three pieces, and imagine how difficult that would be to remove. There's our socket, and our implant is placed right into the socket. Again, we're placed into the septum. Over here there really isn't a septum, so into the groove where the septum would be, with a slight cheat towards the palate. Again, we're going to use the PMMA sleeves from Adin with a long screw, an ion crown very similar to what we showed you already in the case. You can see what it looks like once we've trimmed it, polished it using our shell. It's almost identical from here on in, except that it has a set screw going right through the middle of it, going into the analog. Here's what it looks like in the mouth. The implant is in place. The provisional is in place. This is absolutely magnificent. Could you believe that this patient came but left with a tooth that looks like this? How couldn't the patient be ecstatic? Really, what a service. How couldn't the referring dentist be ecstatic? It's important to note, this is a case by Dan Gober, that it's important in cases like these not to use a a cow horn to remove this, even though that would be very easy. It's important to go ahead and section our tooth so that when we section it, we can end up with this little septum. And what that's going to allow us to is to go ahead and place an implant right into that septum. Let's look at a quick video of a maxillary tooth that we're going to do, an immediate implant placement, and how we're going to do that. Here's what our tooth looks like. And so we're going to go ahead and extract that tooth and replace it with an implant. We're going to do this by sectioning it. And in this particular case, we're going to section it in several ways. We're going to begin by sectioning the crown with a horizontal cut, being very careful not to nick the adjacent teeth. We're going to go ahead and use an elevator to snap the crown off once we've loosened it. And what we're going to be looking at is the chamber, and now we're going to go ahead and separate the chamber into the roots where we know anatomically they exist, both from our knowledge of anatomy and from our radiographs confirming that we have the roots that we have. So in this particular case, we have 3 roots. We're going to go ahead and section it as we usually do with maxillary first molars. And we're going to be very, very careful. We're going to luxate those teeth out very, very carefully. And we're going to use, again, the Titan forceps to grab it, twist it. They have these beaks, as you can see, that go underneath, subgingivally, and in this case maybe even subcrestally. And very carefully, we're going to maintain all of that buccal plate. You can see exactly how we're doing it. We're going to apply pressure with an elevator. We're going to grab it. In this case, we're using a rongeur because it's smaller and thinner. It's already loosened. We're going to go ahead and clean our socket out. Make sure there's no granulation tissue, and you can see how nice it is reconstructing. But most importantly, what we're left with is a tooth, and we're left with that core. We're going to go ahead and instrument our core right into that. We're using a B&R system over here to go ahead and create our osteotomy. Very often there's a sinus over here, so we're going to instrument very, very shallowly, paying careful attention to where our sinus is. Also, our bony walls are going to be very, very thin all around because it is interradicular. We're going to be very, very careful. Over here, we're going to, again, a shout out to Geizlich and Bioas. We're going to graft the socket with some Bioas. You can see very carefully we're doing that, and the purpose is so that we're going to maintain our bony housing. We're going to maintain our gingival complex, which is supported by bone over here. And then we're going to go ahead and we're going to use osteotomes, and you can see how we're doing that. We're finding our osteotomy. We're wobbling very gently, widening it. The osteotome set comes with sequentially larger osteotomes, and one by one, we're going to widen it. We are going to use a little mallet and tap it up a little bit. And you can see what we're doing is we're breaking the floor of the sinus and elevating it with the Schneiderian membrane. Over here, we're going ahead and we're placing our implant. The Adin implant comes, and now comes mountless as well, because there's a big quest for it. But at this point, before we had the mountless, and I still use these, I prefer these now, it comes mounted. It comes with a very, very nice mount. It's not screwed in, it's snapped on, but it allows us to handle it, to carry it. You saw how we placed it by hand, and I like the tactile sensation of being able to feel how we place it. You saw just how hard it was when we placed it. I'm going to put an extension on, and you can just envision how I'm working and how much pressure I have to use to put it in. And that's, again, because of the design of the Adin implant. With its tapered spiral core, it's going in at tremendous torque and totally supportive, even though we're going into an extraction socket in maxillary bone. And you can see very clearly what it looks like over here. We're going to graft the remaining walls with some Bioas. And what it looks like right over here, you can see over here where we've elevated our sinus, placed into the center. Really a terrific result, and a terrific service that we can provide to our patients by doing extractions and immediate placements, and even more terrific service that we can provide to our referring dentists, because they send us a patient, usually the same day, the next day, they get the patient right back with an implant in place. And what they need to do is simply wait for 10 or 12 weeks to go ahead and do a final restoration, as opposed to the long, drawn-out process that they're all accustomed to. Let's look at this one last case. Let's look at this let's look at this. I apologize for 1 second. Let's look at this one last case. and then we'll open it up for some questions. What we're going to do over here is something called orthodontic extraction, where we're going to use orthodontics to help us. And so this is what this case looks like. Our patient was really resistant and reluctant. It was an adult patient who just didn't want to have any braces. The patient had occlusal issues, and you can see how much bone we've lost over here. Unfortunately, what we've also lost is a lot of buccal plate. And you can see how the tooth is in buccal version over here. We have this tremendous recession, and there's no bone over here. So if we want to place an implant to restore this, and we want this to heal nicely, what we're going to need is to regrow this bone. And the best way to regrow it is by very, very slowly extracting the tooth, by moving it into an occlusal position, because we know if we move it slowly enough, the bony complex around this little piece of tooth down here that has bone around it is going to move with it. And so ultimately the bone from here is going to move all the way up, and we'll end up with everything there and under it bone. So let's see how we did that. You can see right over here, we put some braces on, or our orthodontist put some braces on. Already over here, we're starting to establish much better contour. We did this in the framework of improving her occlusion, so it was a full mouth work of occlusion, a full mouth occlusal workup. And you can see over here how high our tooth is. So we've already, over many weeks, moving very, very slowly, you can see how we've extruded this tooth. There was no graft material placed over here. There was no surgery over here. What we've done is we moved this tooth occlusally. Every week as the patient came, we needed to cut this tooth down. I guess this photo was taken during one of those weeks where we're going to go ahead and cut that tooth down. In this particular case, thus far, we haven't needed to, but sometimes you need to do endodontics on these teeth in order to accomplish it. And very carefully, you can see how we've extruded it to the max over here, all the way out. You can see what it looks like, and you can see how nicely we're filling over here. And that's what it looks like. Nonetheless, when we went ahead and extracted that very last piece of tooth, we're going to use a membrane, and we're going to graft that to maintain our bony complex. You can see the little amount of graft that we placed over here. And we're going to put a dummy tooth right back on. And this is what it looks like on the radiograph, and this is what it looks like a week or two later once it's healed. And you can see how we're starting to develop a very nice ovate pontic over here, how our gingiva is closed, really a wonderful, wonderful service. And over here, our implant is placed. You can see how we've maintained our papilla, our heights of contour, almost perfect over here. You can see what that looks like right over there. And here's our temporary restoration. Really magnificent, terrific result. That's what our patient looks like. Implant in place, bone totally healed, papilla maintained, nice even heights of contour, no grafting. Really amazing. So let's conclude with some pearls, and then we'll open it up for some questions. We added 10 minutes to the program. I don't know that we're going to take all 10 minutes for questions, but let's open it up and see. Some pearls. Let's make sure, you have to make sure that you have a clot before dismissing your patient. We all know about a dry socket from extractions. Thinking along those lines, we opened up by talking about understanding healing. And this wasn't a lecture on healing, so there's a lot more to say about healing and cells and where they come from. But we need blood in order to form a clot, in order to bring the cells to place so that we have all the cellular elements necessary for good bony and gingival healing. So always begin with a clot. And make sure that you're atraumatic. Communication is key. Some of the cases that we showed you are really pretty complex, and we work with a team. So within my office, I really am grateful. I have a wonderful team. My front staff, my back staff, my assistants, the lab that we work with. Outside of our office, we try to communicate as best we can with our referring doctors. With today's media, it's so easy. Emails, text messages, pick up the phone and call them. It's really very easy just to communicate and make sure that everybody's on the same page. Hindsight is 20/20, so it's very easy to Monday morning quarterback and say, this wasn't right, that wasn't right. We do take a lot of pictures, and we do that in our office for the purposes and benefits of learning from our mistakes. Always treatment plan the ridge prior to extraction, regardless if it's for an implant, pontic, or removable appliance. Because once you remove that bone, it's not coming back easily. So always try to keep the bone in place and treatment plan accordingly. Plan and plan and plan, but if it doesn't work, you need to process, react, and adapt, and then plan again. So things don't always work out. We learn from our mistakes, and that's okay as long as we don't make the same mistake over and over and over again. Don't put anything into a socket unless you totally understand what it does, how it does it, and why you're using it. Just because a rep tells you so is not a good enough reason. And so we're all accustomed to being detailed by some very powerful companies with deep pockets. We all go to meetings and we see all these great products. And a lot of practitioners are enticed by the model of being able to charge a fee in order to graft a socket. But a bad graft is really a horrific nightmare. And it's much better not to have any graft than to have a bad graft. And so you have to understand why you're grafting. You have to understand how to graft before you go ahead and squirt some material into a socket. Make sure that you take Radigas and confirm that all root fragments were removed. Whenever you enter the extraction arena, it's always very, very easy to break a little sliver of a tooth or break a root that you didn't know existed. It's nothing that I myself haven't done. Needless to say, I always try not to. I'm sure it's going to happen again, even though we try very hard not to. But we do pay attention to radiographs and to CAT scans, and we always look at the root when we extract it to make sure that it's rounded and that we have the entire root that we're extracting. I already talked about learning from your experiences, and it is important to learn from your experiences. I want to thank you for logging on and listening.